So welcome everyone. I was told it's a wet and miserable night outside. I'm actually in a shopping complex in the underground level, so I'm not sure what the weather is out there. But anyway, warm welcome to everyone. Our webinar tonight, we got 3 speakers. Our first speaker was supposed to be Dr. Harpreet Aurora. I think she's a little bit delayed, so we'll start with our second speakers. We actually have 2 speakers, and they are both physiotherapists at the Royal Prince Alfred Hospital. So it's Susan Duchetto and Emma Lilly. Their topic is on the physiotherapy for pelvic floor problems. So please welcome Susan and Emma. Thank you.
Oh, thank you very much for the invitation to speak with you tonight. We'll just grab, we'll share our screen now to get the PowerPoint up. Are you able to hear me okay? Is that all right?
Very well, thank you.
Great, thank you. So thank you for the opportunity to discuss with you tonight our physiotherapy service at RPA and the pelvic floor conditions that we see. My name's Emma and I'm one of the women's health physios at RPA, and Sue's going to take over the second half of this presentation to do the rest of the discussion, but I'll start us off tonight. So we'll start off just with talking about how to refer to our women's health service, some of the common conditions that we see, how to assess these conditions and the management strategies we use. And then we'll talk you through a little bit of a pelvic floor assessment that we do in our clinic. So our women's health physio service, we have a small team of physios. There's 3 of us physios who work part-time at RPA, and we cover inpatient, outpatient and clinic services. Because we are such a small team and we cover many services, that's just a funding thing that we have a small team. Sometimes we do have a bit of a longer waiting list, which we just wanted to flag with you, but we do our best to triage the patients and see them in a timely manner depending on their condition. But often it is a bit of a longer wait than if a woman sees a private physio. We accept inpatient and outpatient referrals from a range of people, consulting medical teams, GPs, specialists, midwives, and parenting educators. In terms of our services, we provide an inpatient service, and we receive these referrals through a ward-based electronic referral system. And we see women with antenatal and postnatal musculoskeletal issues such as pelvic girdle pain and abdominal separation. We see a range of pelvic floor conditions, things like incontinence, pelvic organ prolapse, urgency, and chronic pelvic pain. We commonly see a lot of 3rd and 4th degree and complex pelvic tears. And sometimes we see a couple of hand conditions such as carpal tunnel and de Quervain's veins, which we refer onto hands as required as well. Our outpatient services we receive via fax, and we triage based on the priority and urgency of the condition. These referrals that we accept, we see women from the RPA catchment, and we refer women to other hospitals if they're in a different catchment. The referrals that we receive, we triage into 3 categories: acute, subacute, and chronic. So if the woman has an acute condition, we see them within 1 month. These are normally the women that have antenatal severe pelvic girdle pain, which might be limiting their mobility, and 3rd and 4th degree tears. The subacute women that we see in the 2-month time frame are women with pelvic girdle pain that isn't limiting their function as much, acute pelvic floor dysfunction, and abdominal separation. And our chronic category is a minimum wait time of about 3 months, and these are the women that have symptoms of incontinence and pelvic floor dysfunction, which has often persisted for more than 12 months. So this is the referral form that we receive, which is faxed to us. We'll pass this on to Lydia and make this available to you after tonight if you wish to refer a patient to us. And please contact her if you'd like a copy. So we receive this via fax, and this provides us with the details that we need to triage the patient. Other outpatient services that we offer, we just started last year a new postnatal virtual exercise class. And this was a bit of a COVID initiative that we developed. We triage women based on assessment as to whether they're suitable for the class, and then we're able to modify this depending on their conditions. We're also involved in a couple of clinics. So from May this year, we're starting to have a role in the 3rd and 4th degree tear clinic, which is a multidisciplinary clinic. And we also have a pelvic mesh service physiotherapist who's involved in the clinic setting as well. So now we'll just go through some of the common conditions that we see as physiotherapists and how we assess and treat them. So firstly, we see a lot of pelvic girdle pain. This is a very prevalent condition. Before 20 weeks, about 33 to 50% of women will be experiencing symptoms, 60 to 70% by trimester 3, but only 20% of people are classified as severe. The good news is that a very reassuring statistic that 99% will recover within 12 weeks postpartum. In terms of outpatient management, when we see these women, we make sure they know that they're very likely to recover within the first 12 weeks postpartum at least. So we educate them about what the causes are and the likely outcome. And it's important to let them know that there's nothing that's going to make them feel fully better, as it's the postural changes and hormones that are causing their pain, but we're going to make them try and feel as comfortable as possible. So a lot of the discussion is about activity, modification, and lifestyle changes. If they're really active, it might be limiting what they're doing a little bit more, pacing themselves, and some postural changes. We often give them support wear, such as the belts that are shown, compression as well, and that just helps to counteract the postural and hormonal changes which are causing the issues. We can prescribe stretches and strengthening exercises as required. Sometimes the pool's a good option to eliminate gravity, and there's always the option of ice and heat to help symptomatic relief as well. For inpatients, if the woman is admitted with this, it's often a more severe presentation, and again, providing reassurance and avoiding catastrophizing language. So certainly not saying that their pelvis is unstable or anything like that. We offer mobility aids, so give them crutches if they need, and sometimes a wheelchair, and we always follow them up as an outpatient as well. So another common condition is the tummy separation, which we also call DRAM. As an inpatient, we assess the width of the separation. So it's normal to have about a 2 to 3 finger width separation from day 2 after birth. We educate them on how to counteract this. So core strengthening exercises is a big one, which we provide. Every woman gets a postnatal booklet when they're on the ward that has the core strengthening exercises in them. We discuss with them load management, so avoiding heavy lifting, not lifting anything more than their baby initially, how to return to exercise. So minimizing high impact exercise and gradually progressing this. A lot of postural education, trying to avoid flexing through the trunk because that pushes the muscles apart. Any management of constipation if needed, because that straining also pushes the muscles apart. And the use of compression wear, again, is a good thing here as it helps to passively reduce the DRAM and support the muscles. As an outpatient, we see them again if they have a big separation, and if we hadn't seen them already, we educate them via the phone and see them at the 6 to 8 week mark, as there's a natural resolution of the separation around this time. We reassess the width of the separation, give them the same advice as before, and progress a little bit as required, and screen for any symptoms, which may be back pain, pelvic floor issues such as incontinence, or difficulty returning to previous tasks, And at this stage, it's more about the function of the muscles and the symptoms rather than the width of the separation, because they don't always correlate. Another common condition that we see is incontinence, whether that be urinary or fecal. In the female population, about 30 to 60% of women will have urinary incontinence at some point in their life, and 11 to 15% will have fecal incontinence. The risk factors there are mostly the same across a lot of pelvic floor conditions. And when women land on our doorstep, they often say that they might be leaking with coughing, sneezing. They might have an increased urge to go to the bathroom. And might have difficulty controlling wind or poo, and they may have a combination of those symptoms, or a reduced sensation to go to the bathroom. So in terms of management, we get a lot of our information from the ICS, and we published this chart in 2016. But mostly it's a lot of lifestyle interventions. So an example of that would be weight loss. A big thing that we do is pelvic floor muscle training. So in terms of pelvic floor muscle training, for stress urinary incontinence, 50% of women will be dry from their urinary incontinence after having a pelvic floor program, and 80% will have their symptoms improved. And that was shown on a Cochrane systematic review. We go through bladder training for women with overactive bladder. The multidisciplinary approach includes anticholinergics, which can be prescribed, but it's interesting to note that there's a link to dementia with that, so that needs to be prescribed with caution. There are other adjuncts as well, as such as electrical stimulation. There's vaginal devices which can be utilised, such as pessaries. And during this time that the woman is having treatment, it's good to consider continence products as a symptomatic relief. And there's an example that on the Tanner website. They have some really good products, and they're able to send free samples every 3 months if the woman is struggling financially. Another common condition is pelvic organ prolapse. So the prevalence of this is 5 to 15%. Risk factors, again, very similar. Symptoms that women often tell us is a feeling of heaviness in the vagina. They might feel a bulge in the vagina or a dragging feeling in their lower back. And sometimes they feel they have the inability to completely empty their bladder or bowel. In terms of management, it's really dependent on the stage of the prolapse as to how it's managed. As women's health physios, we're most effective in stage 1 and 2 prolapse. This stage involves a lot of pelvic floor muscle exercises, which is recommended by the NICE guidelines. There's limited research on the dosage of these, but 8 reps 3 times a day is a good start for the woman. And there's evidence to show that this can improve the stage of the prolapse by 1. So it can take them from a 2 to a 1 or a 1 to a 0, and that women often feel like their symptoms have improved. Other lifestyle changes that we talk to them about: weight management, avoiding heavy lifting and high impact exercises, and managing constipation as required as well. For stage 3 and 4 prolapses, this is where pessaries can be indicated. This use of pessary is interesting in that it can change the vaginal anatomy over time and decrease the stage of the pelvic organ prolapse. And there's currently research being done as to whether pelvic floor exercises and the use of a pessary in combination is effective. We don't fit pessaries at RPA Physio, so if the woman is a stage 3 or 4, that's an indication to refer them on to gynecology. That's the next step in the public health system for management. If the woman can find seeing a private physio, that's sometimes an option as well, as some private physios do fit pessaries. So I'll now hand over to my colleague Sue, who will take over the rest of the presentation from here. Thanks, Sue.
Thanks, Emma. So just moving on quickly to the next condition, urgency or overactive bladder. Emma's covered a little bit of this earlier in one of the earlier slides, but in our assessment, it's really important for us to understand the patient's current way of managing their problem, They might be reducing the intake completely to try to reduce the number of episodes of incontinence or urges, which actually could be aggravating their problem. So a thorough history there. Bladder diary is a very useful tool to look at their intake and their output, their frequency, and the urge and urge rating to each episode that they, of going to the toilet. It's usually done over 48 hours, and it also is a great tool in offering the patient an insight into their own voiding habits. And sometimes that's enough for them to make a change. I haven't got it listed there, but a pelvic floor muscle examination is really useful, as I'll explain later, has a role in relaxing the detrusor as well, so that can help with deferment. Managing the condition, as I said, Emma's already mentioned a lot of the lifestyle modifications that can be undertaken. The pelvic floor is used to help defer once we teach the patient how to do them correctly and how to use it. Bladder training, retraining strategies include deferment strategies such as deep breathing and staying calm, distracting the mind from needing to go to the bathroom with a mental activity, such as think of you know, what you're going to have for dinner or a shopping list. As Emma mentioned earlier, medications may be prescribed. The study that she was referring to was in 2021, and it demonstrated that anticholinergic use greater than or equal to 3 months increased the risk of dementia by an average of 46%. Furthermore, it was also found that this was duration and dose dependent. Electrical stimulation, such as transcutaneous or percutaneous tibial nerve stimulation, has also emerged in recent research, and it's showing some promise and some benefit for patients in this group. Our next condition is bladder voiding dysfunction, and it's one that we see more often in the ward setting when the hormonal changes during pregnancy and the soft tissue changes during delivery both combine to affect bladder distensibility, bladder urge sensation, and the ability to void. So this can often present as incomplete emptying small amounts of less than 200 mils each time, or large voids of over 600 mils. It could also present as reduced urge to void at appropriate volumes and urinary retention. Besides the case of urinary retention, a bladder diary in our assessment will be really useful in knowing how much the lady is voiding versus how much she's drinking. It can identify postnatal diuresis in those early days, and that can help us to advise the lady on adjusting their times of voids. If a catheter has been inserted and has been removed, a trial of void is undertaken to determine the ability to void. And what that involves is restricting intake to 600 mils in the first 2 hours and allowing the lady to pass urine within the 3 hours of the catheter removing. If retention or incomplete emptying is suspected, then a bladder scanner is performed, and we have a very accurate one on our ward there. Management of the voiding dysfunction includes education to the patient to allow them to understand their situation better, and really to reassure them that in the majority of cases they will make a full recovery. So it can be very distressing, but it's really important that we're there to provide that reassurance and education. Other things we implement are timed voids until the sensation has returned, fluid intake advice of 2 to 3 litres over the course of the day, encouraging routines to assist with effective voiding, such as getting up and pottering around, moving around to allow the bladder to feel that sensation, passing urine prior to feeding the baby or lying down for a rest, and also addressing any bowel regularity issues there. Pelvic floor muscle exercises are taught to women if they haven't already learned it previously, and reassurance is often needed to let them know that doing pelvic floor at this stage is not going to have an adverse effect on their sutures. If urinary retention is detected, that is that there's more than 400 mils of urine retained in the bladder, then the IDC indwelling catheter is reinserted for 48 hours before another repeat trial of void. Now, if that next one is unsuccessful, the patient's usually discharged with a catheter and a leg bag and a night mat bag for a week, and they return to outpatients to see the CNC in the outpatient setting for another trial or void. Third and fourth degree obstetric anal sphincter injuries are something we see both on the wards and in the outpatient setting. So in the inpatient setting, it's important for us to give the patient an understanding of what to expect over the next 6 to 8 weeks of healing, and how they can gradually return to activity and exercise, as well as the information about resumption of sexual intercourse. It is generally recommended to wait for their 6-week review with their GP before having sex, though. Perineal hygiene is very important. So advice such as changing pads regularly, washing front to back after each toileting episode, and wearing supportive underwear with some mild perineal compression all help with perineal comfort and recovery. Information about how to maintain regular bowel motion with a soft formed stool consistency is important for optimal healing of the sphincter injury. Pelvic floor muscle exercises are, of course, encouraged early on, around day 1 or 2, depending on the woman, but they are started very gently and within the woman's pain limits. So generally, we advise 10 gentle pulses 4 to 6 times a day without any hold, so just pulsing. Once they're more comfortable, they can progress onto squeezing and a gentle hold for a few seconds, and then a release again 10 times. And progressing from there, increasing the strength of their contraction and the speed of their contraction. We do advise functionally that the pelvic floor is recruited even in the early days, because that can sometimes reduce the discomfort of actions such as coughing, laughing, sneezing, or maneuvering in and out of bed if they prepare the pelvic floor a little bit. And then, we offer them advice about low impact exercises for at least the next 3 months. They're offered an outpatient physiotherapy review within 6 to 8 weeks, or at 6 to 8 weeks. And following on from there, they are reviewed with the multidisciplinary clinic at 3 and 6 months. Finally, a condition we are sometimes referred is chronic pelvic pain. Taking a detailed subjective history is important in this population, as their chronic pelvic pain can be related to a history of sexual trauma. If it's appropriate and with the patient's full informed consent, pelvic floor muscle tone and function is part of our assessment. In addition, an examination of the global muscles around the pelvis is also performed, as a dysfunction in these muscles can be impacted by or cause the pelvic pain symptoms. A biopsychosocial model of care is particularly relevant in the management of chronic pelvic pain. Education about their pain and about how chronic pain comes to be helps with adoption of the other management strategies that we use. These include stretches and strengthening as appropriate, the use of heat packs, exercise advice and choices, in particular towards more low impact exercises, relaxation and mindfulness techniques, pacing strategies, management of constipation and incontinence and other pelvic floor issues, the use of vaginal dilators to assist with graded exposure, the use of non-irritating lubricant, and a referral to a counsellor as required. On this slide, you'll see some great resources that you can access online for yourself, for yourself or the patient. In our clinics, we use often the handout on the right-hand side, as it combines the mindful breathing and the stretches to the hip. Okay, so I know that we're running a bit short of time, so I'll just try and quickly go through this last session, last part here. I thought it might be useful for you to have an idea of what's involved in a physio assessment of the pelvic floor in the outpatient setting. So using a model initially to help the patient understand the anatomy of the pelvic floor is really useful, and we refer back to that when we're doing the internal examination. If the patient has a visual idea of where they need to recruit in their pelvis, it can be quite useful. Of course, an informed consent about the procedure is gained prior to visual examination. We look at the skin integrity, the scar and the wound condition, vascularization, the resting position of the perineum, any changes to the cough, to this position with cough or Valsalva. We may look at the anus symmetry at rest and with the contraction, and if there's any laxity at rest, and if there's any evidence of incontinence during the assessment of urine, flatus, or feces. I usually check in with the patient again before I do the internal to make sure they're comfortable for me to progress, to proceed, with the internal. So it's a single finger, non-latex gloved examination with non-irritating lubricant. We assess the resting tone of both the superficial and the deep pelvic floor muscles. We may note anterior, posterior wall presence and position, and the cervical position as well. Our muscle assessment looks at the quality of the pelvic floor contraction performed by the patient. So are they activating their muscles optimally? Is it well coordinated? Are they using any accessory muscles? Their strength is rated on the updated ICS rating, so absent, weak, moderate, or strong, or more commonly the modified Oxford scale out of 5. We may ask them to contract and hold the contraction, and we'll note how many seconds they can hold for, as well as how many repetitions. And also their ability to release is very important, especially in those patients who have overactive or increased tone in their pelvic floor. So how many seconds does it take them to release back down? Fast contractions then are also recorded. So how many can they do before they fatigue, as well as a contraction, holding a contraction against a cough, which would mimic the NAC and allow us to assess how well they can counteract an increase in intra-abdominal pressure. Our feedback and our assessments or our treatment sessions work on appropriate motor control and coordination. And this is really important because it is really hard for a lot of women to breathe through holding a pelvic floor contraction. And we find that if they aren't able to do that properly, then I think the compliance to continue the exercises drops because they don't feel like they can do the exercises properly. So it's really important for us to work on that, to find ways of minimizing accessory muscle use such as the glutes or the larger abdominals. So breathing dynamics may need to be looked at. So just looking at how a patient takes a deep breath in gives us a lot of idea as to whether they're using their diaphragm effectively. And as you can see at the bottom of the slide, the diaphragm, the transversus abdominis, the multifidus, they all work together to create intra-abdominal pressure that the pelvic floor has to respond to. So how they all work together is important. From the assessment and also from the patient symptoms, we get an idea of how we can prescribe an individualized exercise program for the pelvic floor. And also it informs us on how we can advise on their return to exercise. So nearly there, some useful websites for, sorry, I think I skipped a page. Useful websites here that you can access are Pelvic Floor First, which really focuses on exercising. And that's an arm of the Continence Foundation of Australia. They're both very good websites. For the women who really want to go back into jogging, I thought I'd just put this, we thought we'd just put this slide up because they are a nice set of guidelines on which we can advise the patients about how they can get themselves back safely to running. So generally it's recommended not to start running before 3 months, but in those first 3 months, the focus would be on lower limb strengthening, aerobic exercise, core strengthening, and scar mobility, and all of that low pressure, low impact type of exercise. At 3 months, as you can see on the bottom right-hand side, a comprehensive screen is recommended prior to a graded return to running, such as couch to 5Ks. So that wraps up our talk today, and we hope you found it useful. We're on Missedon Road, just down the road from the main entrance of the hospital. There's a handy little semicircular driveway. Patients can just get dropped off and come in. Our details are there, our emails are there. If you've got any questions, feel free to contact us. Thanks.
Well, thank you very much, Susan and Emma, for such an informative talk, especially to know that we, as GPs, we can actually refer to Prince Alfred. So thank you. Now I'll go through some of the questions, please. So the first question is, for abdominal separation, how long after postpartum can a woman do sit-up exercises?
I can answer this one if you like. So it's really dependent on the woman and their stage in recovery, and if they have a larger separation that's persisting and that's symptomatic, that might change when you start doing sit-ups with them again. It depends how their activation is going as well. So everyone's individually assessed if we're seeing them, but as a general rule of thumb that we tell people is 3 months after having a baby that you're not to do sit-ups for. And that's because there's a significant hormonal decrease at around 3 months, and that won't be affecting pushing the muscles apart as much.
Thank you. So the next question is, what exercises then would you recommend patients to do that may help with improving their abdominal separation? Is there anything simple that we can ask them to do?
So for abdominal separation, if a woman has had a baby at RPA, we have a little postnatal booklet that they receive, and that has the core strengthening exercises that we recommend they commence after having their baby. And that will just help with the initial activation and bring those muscles back together. Otherwise, if we're seeing them face-to-face, we give them an individualised program that we prescribe for them, and we gradually progress this over time depending on their symptoms and their function. But all the core strengthening exercises are basic sort of activation of the deep tummy muscles, back muscles, and the pelvic floor, so that cylinder of core muscles. And depending on how the woman is initially, we would progress that along. A lot of women also do really well with postnatal Pilates or yoga. That's a great way of activating the core. And if they go specifically to a postnatal class, that means that they'll be avoiding that sit-up position that we don't want them to do. So it won't be exacerbating any tummy separations, and it won't be too advanced for them. And that's usually a really nice, gentle level for women to start. And they can usually start that around the 6 to 8 week mark. Before that, it's much more gentle activation.
Good, thank you. Actually, on that abdominal separation, how wide would it be before it's alarming?
So 2 to 3 finger widths is normal after having a baby. Yeah. So the muscles separate significantly so bub can grow, and then afterwards they will remain separated. And we like to see it around 2 to 3 finger widths or less. But if it's more than that, that's when we're actively really working on bringing it back together. But regardless, they should be doing core strengthening exercises and bring it back together.
All right, good, thanks. Next question is on prolapse. So how can we tell it's a rectal seal or cystocele?
I can
Do you want to answer
to that. Yep, sure. With a speculum, one way to determine that is if you place the speculum into the vagina, and if you're looking for a cystocele, then the speculum supports the posterior wall of the vagina, and you can ask the patient to do a cough or a Valsalva. And if it is a cystocele, then you'll see the anterior wall of the vagina descend. Then to determine if it's a rectocele, so it could be an anterior wall prolapse and not, rather than a bladder prolapse, but in any case, anterior wall would suggest that there's lack of support to the bladder. Then for a rectocele, then you would place the speculum more anteriorly, and then again ask the patient to cough or bear down, and you should see a descending movement of the posterior wall. The texture of the prolapse as well can be an indicator of what the prolapse is. So if it's got a bit of rugae, that's more likely to be posterior wall. And if it's a smoother type of texture, that's more indicative of a cystocele.
Thank you. So the question is still on the prolapse. So it says here, people using vaginal pessary for prolapse, a lot of them complain of PV discharge. Is there any way that they can minimize the discharge?
I guess if a patient was complaining of PV discharge, I would like to know how long they've had the pessary in for. And if the PV discharge is malodorous, that can indicate, so if it's been there for a long time, it's malodorous, it may be an indicator of infection. So it's best that they have it removed if they can remove the pessary on their own, or go and see their GP or gynecologist to remove it for them. They really should not have anything unusual in terms of vaginal discharge when they have the pessary in situ. And they should be getting that changed and the vagina examined regularly to ensure that the walls aren't being compromised from the pressure of the pessary.
Good, thank you. So for bladder training, how often should the patient empty their bladder?
Okay, so, Emma, are you okay for me to speak?
Yeah, if you want to answer it, that's fine. Yeah.
Sure. Okay, so early in the postpartum period, when they don't have much sensation, if they don't have much sensation, yeah, every 2 hours is great. It also depends on their hydration. So if they're not drinking much, then every 2 hours you'll end up with small voids. So I guess based on how much they're drinking, that would guide you on how often they should be voiding. But if they're drinking about 2 litres a day, I would expect they're going every 2 to 3 hours.
Very good. So again, on pelvic floor retraining, the next question asks, what exercises would you suggest for patient to do?
In recovery pelvic floor exercise program?
Yes.
So do you mean general exercise to help with the pelvic floor recovery, or specifically pelvic floor exercise?
I suppose it's for recovery.
Oh, okay. So maybe if the pelvic floor is recovering, what sort of exercises would we recommend?
That's right, yes.
Right. Okay. So something like walking, swimming if there's no more, if there's no longer any vaginal discharge and wounds have all healed, scar has healed. Then walking, low impact cycling, if that's something that they enjoy doing. Yeah, anything else? Yeah, walking, swimming, cycling. Later on, you can start with the Pilates as well. That helps with the pelvic floor as well, because with Pilates, you need to engage the core to prepare for the movements in those exercises. So that indirectly helps with the pelvic floor. I think that answers the question.
Yes, okay, thank you. So we're back to a question to abdominal separation. So again, it's basically why would it be before we have to actually refer someone for surgical intervention?
I can answer, I feel like. In terms of the width of the separation, as I was saying, it really depends on the symptoms the patient is having rather than the width of the separation. There's a lot of women that have a persisting separation that may not have any symptoms and can lead a normal life whilst they have that, as they may have good compensatory recruitment of other muscles. But say the woman does have a persisting separation, which is quite large, and they haven't been able to regain their normal function, and they're experiencing symptoms, severe symptoms that are affecting their quality of life, that may be an indication to refer on, but that would only be when all other options have been exhausted. So we've tried conservative management and things like that. Personally, I have never had a patient that has had to go on to have surgical intervention. I did work with someone once who had surgical intervention for their abdominal separation. That was a midwife I was working with, and we talked about it socially. And her symptoms was she had really bad back pain and a lot of pelvic floor issues, and she couldn't get any sort of improvement with any physio, which she'd done for years, and she was quite diligent with doing pelvic floor exercises and core strengthening exercises and had lost weight. But this was just really persistent, and that's the only person I know of that has had surgical intervention. Did you have anything to add, Sue?
Yeah, so I agree with everything you say. Definitely any back pain symptoms, pelvic floor symptoms. Sorry. I think also if there seems to be a lack of, if there's a risk of herniation, that be very important, and also how far down the track are they postpartum. So I think at least 12 months, if there aren't any signs of herniation, I think waiting at least for that 12-month or at least the breastfeeding stages past before then you make any kind of consideration of surgical intervention.
All right, good, thank you. So actually there's a question about the core, and I have to say I'm not sure what the question is. So if maybe the person can clarify the question. So anyway, I'll move on to the next.
I understand that question, Dr. Lee.
Sorry?
I think I understand that question.
Oh, you do? Okay, please.
Yes.
Yeah.
Okay, so maybe what that's about is the patient's gone to an exercise class and they've cued the core, but then maybe the physio has said, don't hold the core, don't contract your core. So in some patients, if they've been identified to have increased tone in their pelvic floor, they're doing exercises that overactivate the pelvic floor, and the core can actually exacerbate the symptoms that they have from having increased tone in their pelvic floor. So I think that's probably what's happened there, because the majority of the message out there is pelvic floor, turn on the core, get that strong. But for some women, they'll be fine without contracting their pelvic floor because their pelvic floor is already increased in tone. So the risk of them prolapsing through an exercise is not as high as someone who has a weakened pelvic floor. Does that, yeah, if the person could just indicate whether I was on the right track, that would be great. Thanks.
Okay, the next question is about prolapse. So for the vaginal pessaries, how long can it be in place before it should be cleaned, and does it need to be removed before sex?
Emma, you want me to go?
Yeah, be fine too. Yeah.
Okay, yeah, usually it's a 3-month review with your GP or gynecologist specialist to have it cleaned, and the inspection, as I mentioned earlier, to be conducted to ensure no soft tissue injury or traumas occurred. Depending on the pessary, they might not need to take out the pessary before intercourse. So it just depends on the pessary they're using, because there's a plethora of them out there.
Good, thank you. So the next question is
sorry, I have to jump in, Dr. Lee.
Yes.
We're running out of time.
Yes.
Could I please kindly ask Susan and Emma to answer remaining questions by typing the answers down?
Yes.
And we will move on to our next speaker. Thank you.
Thank you.
Thanks. Thank you, everyone.
Thank you. Our next speaker is Dr. Susanna Graham. Dr. Susanna Graham is a specialist general surgeon with subspecialty training in breast surgery. She has experience and expertise in the use of oncoplastic techniques for the treatment of breast cancer. Dr. Graham holds a VMO appointments at Chris O'Brien Lifehouse, Carina Private Hospital. She's a full member of Breast Surgeons of Australia and New Zealand, the Specialty Society for Surgeons Treating Breast Cancer. In addition to her clinical practice, Dr. Graham is committed to education. She's the education lead for breast surgery at the RPAH Institute of Academic Surgery. She coordinates a unit of study for the University of Sydney Master of Surgery for breast surgery. Dr. Graham regularly teaches education sessions for junior medical officers and surgical registrars, as well as coordinating exam preparation courses. She's also passionate about mentoring the next generation of female surgeons and also quite a number of surgical registrars. So Dr. Graham, her topic tonight is on non-cancerous breast lumps and management. Thank you, Dr. Susan Graham.
Thank you, Dr. Lee, and thank you everyone for inviting me to speak. I'm unable to share my screen whilst Emma and Sue, whilst the other screen's being shared. So
Emma, can you stop sharing, please?
Perfect.
So thank you.
Thank you. So as Dr. Lee said, I've been asked this evening to talk on non-cancerous breast health and common, I guess, breast presentations. And talking about assessment and management options in that case. There we go. I'd like to begin today by acknowledging the Gadigal and Wangal bands of the Eora people, the traditional custodians on the land from which I present. I'd like to pay my respects to elders past and present and extend that respect to the traditional custodians of the various lands on which you all sit today, and the Aboriginal and Torres Strait Islander people participating in this webinar. So who am I? As Dr. Lee introduced me, I'm Susanna Graham. I'm a specialist general surgeon with a special interest and subspecialty training in breast surgery, and that covers covering benign and malignant conditions. But I'm also a wife and a mum, and those are two very important parts of my life as well. So where do I work? So announcing a little bit of a change for those of you that may have I guess referred or had patients seen by me previously. Professor Cindy Mack and I had rooms in Newtown, but we're in the process of moving. The furniture moves tomorrow into Chris O'Brien Lifehouse for our private and public work. So our private rooms will also be located within Lifehouse, and we have joined together to form the breast care centre with 2 breast physicians joining our practice, which we're really excited about. So we're undergoing sort of a big update, and there'll be a new website coming shortly. And so that's very exciting. I also consult in Miranda, and I also go to Port Macquarie once a month as part of Chris O'Brien Lifehouse for a specialty breast clinic in Port Macquarie. So that's a little sneak peek of the of what is to come. So to start, what is benign breast disease? So a spectrum of disorders that comes to clinical attention as imaging abnormalities or as palpable lesion or any other finding in the breast on physical examination. In this, within this sort of broad heading, I think the most common breast-related complaints are breast pain, breast lumps, and nipple discharge. And my plan for this evening is to go through those topics and hopefully come up with some strategies in the assessment and management of those. So I thought I'd just begin by going through breast assessment initially. So when taking a breast history, obviously, like with anything, it's a history of the presenting symptoms and making sure that if there's a lump, we find out about the site, where, and also about site of breast pain, or and also with nipple discharge. So which breast, whether it's one breast or both, whether things are diffuse or focal, with nipple discharge, whether it's unilateral, bilateral, single duct or multi-duct, the duration of symptoms, when they were first noted, the relationship to menstrual cycle or exogenous hormones, and any other associated symptoms with their presenting symptoms. So lump, pain, breast asymmetry or skin dimpling, nipple changes and nipple discharge. Other relevant history, so any previous breast problems or investigations, any risk factors, and in particular family history. And of note here, family history, you actually need really quite a strong family history in order for it to increase your risk profile. So it's, you know, a number of at least sort of 2 first or second degree relatives with other high risk features such as young age, bilateral breast cancers, a woman who's had breast and ovarian cancer. So a number of women worry, I think, that they have a significant family history with only one or two, you know, second or third degree relatives, but this in fact doesn't increase their risk significantly. Taking a history about hormonal status, menstrual history, parity, recent pregnancies and breastfeedings, any current medications or recent medication changes, and in particular any exogenous hormone use. Lifestyle factors which can play a role in breast cancer risk include alcohol intake, low physical activity can increase, has been shown to increase your risk, a smoking history, whether they've had any recent imaging, and whether they've had any previous radiotherapy which may affect the chest, whether there's a history of any previous or recent breast surgery, and that includes cosmetic or aesthetic breast surgery, any recent breast trauma. I think we've all gone through a breast examination, and I essentially looking for asymmetry, skin changes and nipples, and on palpation, just doing a thorough breast examination, examining the entire breast. And to be honest, it doesn't matter in what direction you do it, as long as it's systematic and you can ensure that you've examined all 4 quadrants of the breast and up into the axillary tail, and examining the regional lymph nodes, so axillary and supraclavicular foci. When sorry, why is that going funny? Breast imaging, I think most commonly we would all, I'm sure you all know, breast ultrasound and mammography are probably the 2 most commonly requested. Breast imaging. Tomosynthesis is often sort of just added on now. So that's 3D mammography, so giving us, I guess, more detail about the breast, increasing the sensitivity and specificity of mammography, helpful in dense breasts, and improves our pickup rate of lesions compared to 2D mammography. Breast MRI, unfortunately, Medicare have decided that rebates in the setting of investigating a symptom or lump are really in the hands of what Medicare deem as specialists in this setting. So usually something that in terms of benefit for the patient with the Medicare rebate, we're very happy to organise. There is a system for reporting breast imaging, which should be standardised, and a summary of an assessment category should be assigned to the imaging that is reported. This gives you an indication of how likely or unlikely the finding is to be malignant or benign. And essentially anything that is category 1 through to 4A, we've got a lower suspicion for malignancy. Anything at 4B or above, we're getting suspicious for malignancy. So I put in a few polls just to keep it interesting and keep everyone involved. So if everyone would like to answer. So what is the triple test? 1, 2 or 3? Is it made up of clinical assessment, ultrasound and mammogram, clinical assessment, imaging and non-excisional biopsy, or an ultrasound, mammogram and non-excisional biopsy? A couple of questions that are coming through I can start answering. So how to calculate breast cancer risk in an individual? Is there a formula? So I feel the best way of doing this, there's a website through Peter McCallum called iPrevent. So if you Google iPrevent, it takes you to a website that will take you through to essentially a questionnaire. I will often get women to do this not in front of, well, I ask women not to do this sitting in front of me, because it takes up to about half an hour. Sometimes they go into a very detailed history about family history in particular. The thing that I really like about iPrevent is it gives you not only the numbers, but also a pictorial summary of that individual's breast cancer risk compared to the general population. So, and also then goes into risk management strategies, again, tailored to the individual woman. And they're not just, medication or surgical risk modification, but also imaging strategies, as well as lifestyle modifications. So the triple test is actually the combination of clinical assessment, imaging, and non-excisional biopsy. So the 3 components are the clinical assessment, the imaging, and the non-excisional biopsy. So the clinical assessment is your history and clinical breast examination. Imaging, usually, I guess, screening imaging is your mammography, and combine it with an ultrasound in appropriate clinical situations. And then a non-excisional biopsy, which can be a core biopsy and or a fine needle aspiration biopsy. And again, I'll go through when to use which type of biopsy, and we'll talk a little more about when to use which type of, imaging and biopsy. So how accurate is the triple test? Why do we use the triple test? So in the setting of if we know that the clinical assessment, imaging and needle biopsy, if we do all three, we will find 99.6% of cancers that are there. So we find less than 1% of cancers are missed in this setting. If all three components are concordant with benign findings, there's a less than 1% chance of cancer. So it's really good at finding cancer, and it's also really good at, I guess, excluding a cancer. But if any component of the triple test is not benign or is indeterminate or suspicious, then it is deemed positive and further investigation must be performed. So onto the more specific, I guess, topics. Breast pain. It's a really, really common condition. I think probably about 70 or 80% of the women that come through even to see me, whether that be in rooms or in clinic, will describe some sort of breast pain. I think almost all women will experience it at some time in their life. It is rarely a symptom of cancer. We not infrequently find women who have some sort of breast symptom, like some, I guess, indistinct or quite vague pain, and it prompts them to see their GP, and appropriately breast examination and imaging is performed, and a cancer is identified. It's rarely the cancer itself that's causing the symptoms. And, I often have women who come in and say, oh, I had left breast pain and we found my right breast cancer. So it's often in the context of, it's a coincidence that they have described a symptom and it's prompted appropriate screening, imaging, or appropriate assessment. And it coincides with their diagnosis. Occasionally, infection or injury to the breast can cause breast pain, so something like shingles. Many women, though, continue to experience ongoing pain that doesn't have an obvious cause. And I think for me, if I have a woman who has pain without any other sinister or suspicious underlying features on their clinical assessment with normal breast imaging, I would be happy to reassure and come up with some strategies for managing their pain, but sometimes the pain is more difficult to manage. Breast pain can be classified as either cyclical, non-cyclical, or extramammary. So cyclical pain is the pain associated with hormonal fluctuations of the menstrual cycle, usually that increased pain sensitivity and tenderness in the breasts in the premenstrual period that dissipates with menstruation. Non-cyclical breast pain doesn't follow the usual pattern of menstruation. It can be constant or intermittent, and it's more likely to be unilateral and variable in its location within the breast. Extramammary pain, musculoskeletal is the most common here, with chest wall, spinal or paraspinal disorders contributing to a perceived breast pain. Trauma can be a cause of perceived breast pain and other medical conditions. So weird and wonderful things can present as pain in the chest or breast, biliary, pulmonary, esophageal, or cardiac disease. So essentially what we're doing in an assessment for breast pain is examining for signs that may suggest an etiology, and also identifying any signs that may be suggestive of a breast malignancy, so that we can to ensure we don't miss that. So the clinical evaluation is of presenting symptoms and risk factors for breast cancer, with on physical examination, inspection and palpation, obviously trying to elicit any signs that may either elucidate the underlying cause or be suggestive of something else going on. So a 42-year-old woman sees you with unilateral, diffuse, intermittent, non-cyclical breast pain. Clinical assessment reveals no significant risk factors or abnormalities. What investigations would you recommend? So I can sort of start answering some more questions whilst we're answering questions. So the role of subtraction mammogram, I think that's the role of contrast enhanced mammography. So we're increasingly seeing that being utilised by a number of radiology practices around Sydney. So it's actually a really good test. We know that it increases the sensitivity and specificity of mammography and up towards that of MRI. So increasingly it's being used more to identify abnormalities and again, another great tool to utilize in the setting of increased breast density when mammography is not as helpful. So essentially it just gives us more information, particularly around the vascularity of a lesion, and certain patterns of vascularity can indicate a higher degree or lower degree of suspicion with respect to a lesion that might be identified on mammography. But in order to have it, you do need a cannula and contrast-based mammography, iodine contrast. So the same, contraindications or risks of iodine-based contrast that are present for things like a CT scan with IV contrast are there in the contrast enhanced mammography. So yeah, I would agree with the majority. So ultrasound and mammography, I wouldn't reassure alone in a 42-year-old woman unless they had very recent up-to-date screening imaging. So I think given that they are young, I would err on the side of doing ultrasound and mammography to increase your sensitivity and specificity of finding an abnormality. And generally in anyone who has a symptom over the age of 40, I would recommend doing both a breast ultrasound and mammography. So when am I suspicious in someone who presents with breast pain? Someone who has a suspicious clinical finding like a palpable mass, any skin changes, particularly if they're unilateral, any blood-stained or serous nipple discharge associated with the pain, and anyone with a focal breast pain that is persistent and in the same place with a suspicious lesion on imaging. When do I reassure? Particularly women with diffuse breast pain with normal clinical assessment and imaging, anyone with focal breast pain with normal clinical assessment and normal imaging, and someone who on clinical assessment has extramammary pain. So I find quite useful in terms of the examination in order to differentiate between a breast versus chest wall is to get a woman to sort of lie 45 degrees, which enables you to displace the breast tissue off the chest wall, and you can sort of get in behind the breast a little bit better and actually palpate the chest wall rather than palpating the breast on the chest wall. So management of mastalgia, there's lots of strategies. Unfortunately, they're not all grounded in solid evidence base. So with cyclical breast pain, well-fitting bra, simple analgesia, you can try vitamin B1 and B6, but being aware that long-term use may have neurological side effects. So usually 3 months duration of treatment there. Evening primrose oil is something that does have some evidence, particularly in the cyclical breast pain arena. It certainly doesn't have any significant adverse side effects or but it is, I usually say to women, you need to take it regularly for 3 months. And if it's giving you some benefit, continue to take it for 6 months, but you need to take it for 3 months before deciding that it's not actually of any, giving you any symptom relief. Avoiding and reducing salt, caffeine, smoking, and fatty foods. I usually tell women not to do everything at the same time, because then you've given up everything that you potentially enjoy and you don't know which one it is, even though a lot of those things are probably things that we should be having in moderation or not at all anyway. Prescription medication is really limited to women who are quite severely affected by the pain and it's interfering with their quality of life. So you can see it sort of goes from fairly benign treatments to those far more, I guess, significant treatments that have significant side effects or possible, interactions. So really with, keeping prescription medication for the really severe patients, the patients with severe pain, non-cyclical and extramammary breast pain, well-fitting bra, stretching exercise, simple analgesia. I think never underestimate the benefit of some good simple analgesia. A lot of women get a lot of relief from just using a Voltaren gel and massage. Local anaesthetic steroid injections, again, reserved for more severe cases. And some women do still find evening primrose oil helpful in the non-cyclical and extramammary breast pain space. So when do I worry about, so I thought I'd just put a little sort of slide and chat about inflammation, because it is a question that does come up. So non-lactational mastitis in particular. So obviously mastitis, inflammation of the breast tissue, may or may not be accompanied by an actual infection. So a few differential diagnoses, and so infection, periareolar abscess, and mammary duct fistula, so more common in smoking women. In non-lactational mastitis, it's often an anaerobe, so ensure that your antibiotic cover includes anaerobe cover. Idiopathic granulomatous mastitis, really difficult to manage and treat, so it's essentially draining any acute abscess, but it is something that is difficult to manage. Surgical excision does not help them. It can actually exacerbate symptoms and make things worse, and it is something that sometimes immunosuppression is actually required in order to control. So prednisone and even things like methotrexate I've seen be used in this area. When do I worry though? When with inflammatory symptoms in the breast, so rapid progressive inflammation with no improvement with antibiotics, and particularly any signs of inflammation with an established diagnosis of invasive breast cancer. So inflammatory breast cancer, I think, is one of those scary diagnoses that you don't want to miss. It is a clinical diagnosis, so rapid onset of breast erythema, edema, and or peau d'orange, and or a warm breast, with or without an underlying palpable mass. The duration must be less than 6 months. The erythema must occupy at least 33% of the breast, and there needs to be a pathologic confirmation of invasive carcinoma. The traditional sort of, I think we all think about the diagnosis of a dermal lymphatic invasion on a skin biopsy. That's not actually mandatory for the diagnosis. It is still a clinical diagnosis, and the presence of dermal lymphatic invasion on a biopsy confirms your diagnosis, but it doesn't exclude an inflammatory breast cancer. A breast lump. So a growth of tissue that represents an aggregation of coherent material. They can be benign or malignant. It might be solid or cystic, or a combination of the two. And essentially, in any woman with a breast lump, we're aiming to exclude malignancy. Most common benign palpated lumps are fibroadenomas, cysts, fibrocystic change, galactoseals, fat necrosis, and breast abscess. Essentially, again, the goal is to examine for signs that may suggest the underlying etiology and identify any signs that may be suggestive of a breast malignancy in order to exclude a breast cancer. Clinical evaluation for their presenting symptoms and risk factors for breast cancer, and again, inspection, palpation on physical examination. So a 27-year-old woman presents to you with a right-sided breast discomfort and a self-detected lump. The lump fluctuates in size with menstruation, and on examination there's a mobile, non-tender, well-circumscribed mass. What investigations would you order? Whilst we're answering this poll, what is the indication for breast MRI? So there are, I guess, two main categories when we use breast MRI. So in the screening setting for young women who are identified as category 3 or high risk family history who are asymptomatic, they qualify for Medicare rebated MRI as part of their screening. The other setting that we use MRI, and certainly for me as a breast surgeon, when I order MRI the most, so there are 2 item numbers that we have access to in this setting. One is for someone who has clinical symptoms or signs of breast cancer. Conventional imaging has not demonstrated any abnormality, and a biopsy has not been able to be performed. And where if we are suspicious, then can organise an MRI, can order an MRI in order to further image the breast. The second indication, or the next Medicare item number that we have access to, is in the setting of a diagnosed breast cancer, when the clinical evaluation does not, I guess, match the conventional imaging. So I think the most common setting of this would be an invasive lobular carcinoma. They can be quite sneaky and often more feel larger on clinical examination than they seem on their on conventional imaging like ultrasound and mammography. And if they feel bigger than demonstrated on imaging, we're able to organise an MRI in order to further assess the lesion, particularly in the setting when it will affect their treatment planning. So for instance, a woman who's considering breast conserving surgery and has a larger than advertised lump, I would do an MRI in order to characterise the lesion further. The other setting, again, sort of in someone who we're considering perhaps for neoadjuvant chemotherapy, and being able to demonstrate that the lesion is bigger than advertised. In the poll question, in a young woman, so under 30, I would do ultrasound alone at this stage. A palpable lump, I would investigate further, and certainly with a palpable lump, I'd start with an ultrasound, and certainly without any other risk factors, I wouldn't consider mammography in a young woman. So when do you perform imaging? Anyone with a palpable lump should have imaging, and the goal is to identify the lesion so that an image-guided biopsy can be performed. So under 30, ultrasound alone. 30 to 39, I do an ultrasound and consider mammography. Certainly over 35, I would definitely be strongly considering mammography, but in that 30 to 39-year-old, it depends on how suspicious I am and what other risk factors they have as to how strongly I feel about doing mammography. If no lesion is seen on any imaging modality and there is a palpable lump, refer to a breast surgeon, and that's, as I said, one of those indications where an MRI can be ordered in this situation, and occasionally a clinically guided biopsy, or even an excision biopsy of a clinical mass in order to get a diagnosis. When would I not do a biopsy? So I guess the only palpable lump that I don't get a biopsy on routinely would be someone who is asymptomatic, who has a very, benign looking simple cyst on ultrasound, and it doesn't bother them. They may be able to feel it, but otherwise they have no symptoms from it. It doesn't worry them in any way. And so if it's a simple cyst, then I would be happy to leave it alone. What biopsy do you ask for? So there are a number of different types of biopsies: fine needles or fine needle aspiration biopsies, and we can do cytology on that. A cyst aspiration, a core biopsy, or a vacuum assisted core biopsy, or VACB. Fine needle biopsies, they're quick, they're quite simple to do, no special preparations required. The results are available very quickly. In some settings, even if a cytologist is present, you can get an almost instant result. It's usually uncomfortable but not painful. It's a smaller needle. Often it's not even done with any local anaesthetic. However, there may not be enough cells or tissue in the sample to make a definitive diagnosis. You cannot distinguish between an in situ or an invasive cancer because all you're getting is cells, not any architecture. And even if lots of cells are seen, a diagnosis might not be able to be performed. You may still not get a diagnosis. It can still be inconclusive. Cyst aspiration, cyst fluids removed, often under ultrasound guidance, and particularly if it's just serous fluid, the fluid will not be sent for cytopathology. The fluid is only sent when there is a suspicion of there being something else going on. So for a simple cyst where the fluid is not blood stained, essentially the fluid can be thrown in the bin and the patient can be reassured. Core biopsy, it's quite quick. It's not as quick as a fine needle, but it's reasonably quick. They don't need any special preparation. You don't need to fast or anything like that. But more tissue is diagnosed, so we are more likely to get a definitive diagnosis. There are still situations where a core biopsy doesn't give us a definitive answer. If the lesion's missed, if it's discordant with the imaging, it does take longer and it's more invasive. I'm sure we've all seen women with big hematomas after a core biopsy, and there are some more significant side effects associated with a core. So when do you do each certain biopsy? A VAC biopsy, I didn't put a slide, but it's essentially where they suck the tissue in whilst doing a core biopsy, and it takes an even bigger sample than a core biopsy alone. And so if you've got a cyst or a cystic lesion, I'll do an FNA or cyst aspiration. If it's a solid lesion, I will always want to do a core biopsy. I will never request an FNA on a solid lesion. In the axilla, I'll always start with an FNA, particularly in the setting of investigating for breast cancer, because we want to see whether there are malignant cells or not. The architecture is less important in that setting. What do they mean? So you can get a whole bunch of different diagnoses on your core biopsy, and essentially the way that we categorize lesions or in the breast, those that are non-proliferative, proliferative without atypia, and proliferative with atypia. Non-proliferative lesions, cysts, simple ductictasia, mild epithelial hyperplasia, non-sclerosing adenosis, periductal fibrosis, no malignant potential. Proliferative lesions without atypia, 1 to 2 times risk of malignancy. You'll often find that there are some of these lesions which we are more inclined to remove than others. So radial scars, because they can mimic breast cancers on imaging. We'll generally err on the side of doing an excision biopsy in order to exclude malignancy, and intraductal papillomas are often excised because they can keep bad company and may be associated with an area of DCIS. The atypical lesions, the ADH, ALH, and intraductal papillary proliferation with atypia, that's really increasing your risk of malignancy. So 3 to 5 times risk of malignancy associated with when you find these results on a core biopsy. So what is concordance and why does it matter? So some radiology practices will issue an amended report after the core biopsy or other biopsy has been performed. You'll get an amended report issued which says the pathology results were received from blah, and these demonstrate this lesion, and this is concordant with imaging. So essentially what that means is, do the imaging findings match up with the pathology results, and are we happy? So concordant benign, so it's a benign lesion and with benign pathology. So if there is a BI-RADS 2, 3, or 4A lesion with benign pathology, I'm happy to call that a benign lesion. Discordance, though, is when there are benign pathology results with more suspicious imaging findings. If there is discordance, we need to look further. So either a repeat biopsy or a surgical excision should be performed in order to really investigate for why the imaging findings are suspicious, or the clinical findings even are suspicious in the setting of a benign biopsy. When do I operate on a truly benign lesion? So something like a fibroadenoma. Generally, it's for symptom management, or if there is any concern about diagnostic uncertainty. Follow-up for benign lumps, there are no evidence-based guidelines. So it's even it's a source of contention among many clinicians. It depends on the histology. It depends on your degree of clinical suspicion. But what do I do if they've got a benign biopsy with concordant clinical and imaging assessment? I'll often repeat their clinical and imaging assessment in 6 to 12 months. If it's stable, return to routine screening. If it's a biopsy-proven mass that does change over the period of time, reevaluate. Nipple discharge. So release of fluid from the nipple, very common. In most cases, it is part of normal function of the breast and would be physiological rather than pathological. Nipple discharge alone without a lump or any other nipple change is a very uncommon symptom of breast cancer. So just purely, multi-duct nipple discharge is rarely, very rarely a symptom of breast cancer. So what causes nipple discharge? Physiological, so lactational galactorrhea, and pathological, so things like papilloma, ductectasia, DCIS and cancer are the things we obviously want to exclude, and you can have infection as a cause of nipple discharge. Again, goal is to differentiate benign from pathological and to identify those patients who have an underlying abnormality as a cause of their nipple discharge. Looking for their presenting symptoms and risk factors for breast cancer, and inspection palpation on physical examination in order to look for your degree of suspicion. So when do I worry about nipple discharge? I worry in nipple discharge that is unilateral, single duct, spontaneous. So it comes out without any manipulation of the breast or nipple. If it's serous or blood-stained, serosanguinous, and the blood staining can be anywhere from bright red through to that dark chocolate altered blood. And I worry when it's associated with other symptoms like a lump, ulceration, or new nipple inversion. What investigations and when? If they've got physiological nipple discharge, so bilateral multi-duct, and particularly bilateral multi-duct expressible nipple discharge, screen for hyperprolactinemia, and then routine screening, make sure their routine screening imaging is up to date. Pathological nipple discharge, again, depends on their age, under 30, breast ultrasound. If they're 30 to 39 in this case, I would do both an ultrasound and a mammography. Mammography in the case of nipple discharge, because we're looking for microcalcification, which may indicate DCIS. Breast ultrasound will pick up most of your papillary or papilloma type lesions, but mammography is much better at looking for microcalcification, which may indicate underlying DCIS. And again, over 40, definitely breast ultrasound and mammography. Do I ever do cytology? Not really. The only time I use cytology is when I think it will help a patient, I guess, understand the rationale for doing something. So, for instance, if I have a woman in whom I am concerned that they have a pathological nipple discharge, but they're adamant that they don't want anything done, I'll do cytology in order to look for any atypical or malignant cells. I don't, though, use cytology as a way of excluding pathology. So I would not do a cytology to prove that it's benign. I don't. If they have pathological nipple discharge and it's clinically suspicious, even with benign cytology, I would not say that that was sufficient to make me stop worrying or say that they didn't need further investigation or intervention. Core biopsy for any lesion seen on imaging, and the histopathology of that core biopsy will dictate their further management, and a skin punch biopsy for any skin abnormalities. treatment, physiological nipple discharge to treat the underlying cause, medication, endocrinopathies. So there's a big long list. I'm sure you all probably know it much better than I do of medications that can cause nipple discharge. Pathological nipple discharge, though, refer to a surgeon for consideration of microdicectomy or a total or central duct excision. For some women who have that less worrisome nipple discharge, so more of the nipple discharge that I would think of as associated with duct ectasia, so older women, the creamy greenish multi-duct discharge. Sometimes we do perform a total or central duct excision for symptom management when it does become troublesome. Microdicectomy is usually for younger women with single duct spontaneous serous or bloodstained nipple discharge, and we'll do essentially we cannulate the nipple duct and try and excise a single duct rather than taking out multiple ducts. And in most young women who have a microdicectomy, they're still able to breastfeed after that. So take-home messages. Any abnormal result on any component of the triple test requires specialist referral and further investigation. For most women who have a negative result on all three, further investigation is not required. When to refer, any component of the triple test is positive, spontaneous unilateral bloody or serous single duct nipple discharge, nipple areola skin changes which persist and do not respond to topical treatment, inflammatory breast symptoms that do not resolve after 2 weeks of antibiotics, and if any test results are inconsistent with other results and you feel that additional investigation is required. This is a fantastic resource that's from, it's a combined it's from Cancer Australia, aimed at GPs, which is about investigations of a new breast symptom or investigation of a new nipple discharge. I think it's a wonderful resource. It's really well written and very, very, very sensible. So I'd urge you all to have a look at that. These are some of the resources that I use for this evening's talk, which are things that I find useful. So that Cancer Australia guide and up to date. And then that was just a link to the radiological reporting. So it's the American College of Radiology that has developed the nomenclature for breast imaging. Okay, so excuse me, some of the questions that are coming through. Breast screening for 40 plus, is ultrasound necessary if mammogram is normal? So I guess the answer is no, it's not absolutely necessary. There are times when I use ultrasound in combination with mammography when there's any symptom, or if the mammogram demonstrates any abnormality. The other situation when I will use ultrasound in addition in the screening setting is for higher risk women, and that includes, which comes on to the next question, increased breast density. So women who have category C or D Volpara density on mammography, particularly those postmenopausal women who have persistently elevated breast density, are at increased risk of developing breast cancer. So I will continue to do annual screening with mammogram and ultrasound in order to increase the sensitivity and specificity of screening imaging. So dense breasted women, annual imaging with ultrasound and mammography, and tomosynthesis as well, ideally. So that in any woman who I see who has elevated breast density, I will screen annually with ultrasound and tomosynthesis. And I think there's a message here saying that we are at the end of our time. So Dr. Lee.
Thank you very much. That was a very, very clear and comprehensive presentation. It's an excellent presentation.
There was just one question, and I thought I'd just draw you guys to a new resource actually that's just come out around breast implants. And there is a new toolkit for the management of breast implants that's just been published. So I'd urge you all to go and have a look at that, because that goes through a lot of the imaging screening just for breast implant health, in addition to screening for breast cancer in women who have breast implants.